I want to talk to you for a few minutes about the suicide risks of major depressive disorders. In the January this year Journal of American Psychiatry, they said that patients with major depressive disorder or bipolar depression, no, not bipolar 1, which is mania, but bipolar depression, were tested at 3 months, 1 year, and 2 years after discharge from a hospital where they were treated. They had 184 women and 130 men that were tested. And of those follow-ups, 4 completed a suicide and 48 attempts occurred. And we know that there are extreme sexual differences. Men and women suffer their depression differently. Men have higher suicide rates. Women are at higher risk for attempts. That team hypothesized that men had a history of aggression, hostility, substance misuse, borderline personality disorder, past drug use, cigarette smoking, family history of suicidal acts, and early parental separation. And when they took the group down to the most significant symptoms of those patients in follow-up for the most suicide attempts and the most completed suicides, the 2 major things that they had in common: family history of suicidal acts and cigarette smoking. The women had long-term depressive symptoms, childhood history of abuse, fewer reasons for living, subjectively, that's what they said, borderline personality disorder, the lethality of their past attempts, how serious were their past attempts, hostility, subjective symptoms, and cigarette smoking. So interestingly enough, again, when they lowered the study down to the 2 major symptoms of those persons, the 2 most important for women were the lethality of their past attempts and cigarette smoking. So we have to take that for what it's worth. 8% of patients diagnosed successfully suicide annually in this country. I guess we have to define suicide. To me, that's not success on any level. I think we need to change that term to completed suicide. But you very often hear them say they successfully suicided, and it just kind of I get a little bit tear-jerky about when I hear someone say that that was a success on any level. There are lots and lots of medical complications, but one of the most significant ones that we find in all the depressive studies is that the Framingham Heart Study said that depression quadruples the stroke risk in patients younger than 65. Not older than 65, not the elderly, demented, or other patients who might suffer a stroke for other reasons or cardiovascular disease, but in that particular group, from adulthood to age 65, the risk stroke was 4 times greater if they had been suffering from depression. And that was 4,120 subjects. And they may have had a number of other risks, including higher levels of poor adherence to their prescription medication. Again, now these were not the most elderly group that might forget to take their medication. These were people who were not complying in taking their other medications. Poor diet, poor physical activity, and active smoking. Sounds like I'm going to be on a trip with that. Okay, treatment failures. The major reason for failure to respond to treatment for depression is under-treatment. We don't treat them aggressively enough. These patients need to be treated until there are no more symptoms. Not just until they start to respond a little bit or until they're feeling a little bit better. We need to treat them until they're back to their highest level of former functioning. And the 3 things that we think keep people from, there's more than 3, but the major 3, they call the 3 C's: confusion, costs, and complaints. The confusion is they'll come in and say, I took it for 3 days and nothing happened, so I stopped it. Costs, managed care, other reasons they can't obtain the medication, particularly in the indigent population, and complaints is side effects. So just very, very quickly, because my time is just about up, I'm going to touch briefly on voluntary treatment versus involuntary treatment. You probably all know about that, and if not, I'll come back and talk to you at some time. That if we find patients who are so intractably suicidal that they're at risk, then we have to force them into involuntary treatment. And that's the Nevada law 433A and B allows for us to do that. The basis of the chemical imbalance, it's too much or too little, and that's the neurotransmitters that are carried in our bloodstream that tells us that the stove is hot when we touch it, carries that message to the brain. All of those neurotransmitters, when they have either too many or too few, need to be put back in balance. When they're like this in the bloodstream instead of like this, we need to find the right medication. It's like baking a cake. There's a Tom cake and a Mary cake, and so in other words, you have to have the right ingredients for each individual person. Everyone's chemistry is a little different. So we can't just say we're going to use this medicine for everybody with major depression. It is trial and error, and it's very frustrating to the patient. So we have to continue to try different medications and explain to them why we're trying different things. So again, increase the activity or decrease the activity of those neurotransmitters, and we will start to see some outcomes.